Hey guys, we're going to go ahead and get started with our next section in positioning. It's going to be covering the anatomy of the abdominal cavity and also KUB. I do want to tell you there is a distinction between the abdomen and the KUB. In your clinical settings, you'll probably get an order and it will say abdomen / KUB. And at that point, we really need to make a decision what is the indicators for the exam. If the patient's having some type of intestinal, GI issues, colon issues, that's an abdomen. If they're having problems with their urinary system, that turns out to be what we call a KUB, kidney, ureters, and bladder. So you have to make that distinction. Now, a lot of our clinical settings, all of ours in the Alexandria area require you to do basically an abdomen series or an abdomen and not do a KUB. And I'll explain that in just a few minutes. But let's go ahead and turn to our book in page 131. This is in chapter 4, and just start talking briefly about the anatomy of the okay, I'm not getting any PowerPoint. What's wrong? I'm sorry. Okay, there we go. Move the recorder out of the way. Okay, guys, I put this landmark picture back in here. It was presented multiple times throughout intro and again in our presentation on the positioning of the chest, but it is important that we go over these areas once again. I really want you to focus on H. It lines up with the top of the iliac crest. This is L3, this is L4, this is L5, and this, of course, is your sacrum. So the landmark that we'll be using for the KUB is going to be right here at the iliac crest. And if you look right here, there's an indentation of soft tissue on both sides of the patient at the inferior angle of the ribs and the top of the iliac crest. When we medically palpate our patients and we're positioning for pelvis, KUB, or an abdomen, we normally just put our hand right in the side of their patient and just gently push in, and you will feel that curved wing, and it's called the ala, A-L-A, of the pelvis. And that gives you an indication that you're at L4. And there's also a little tiny spot right in here, and it's called the anterior superior iliac spine. It's a little prominent bump. We'll also be talking about it, and you probably have already talked about it since you've covered pelvis and the hip. But anyway, I just wanted to throw this in there. And the other one that I want you to be aware of is J. And again, that is at the that is called the pubic symphysis. Very important that we include the upper margin. Notice how it's kind of wide, about 1 inch wide. But for our KUBs and our abdomens, we have to demonstrate the very top margin of the pubic symphysis. Therefore, we know that we've included all of the bladder, because your bladder is actually going to fit right here, right in front of the sacrum right here. It's going to sit right here. So if you demonstrate that little hard bone right there in the middle, you're ensured that you've included all of the bladder, and this is especially true if you're doing the KUB versus the abdomen. So next I put the, you've seen this before, cavities of the human body. We've already talked about the thoracic cavity. We talked about that. Now here we're focusing on today's lecture, we're focusing on the abdominal cavity right here, and then we have what we call the pelvic cavity. Okay, and both together they call them the abdominal pelvic cavity because they're essentially together, but yet they're actually separated. So on page 131, it says the abdominal pelvic cavity consists of two parts: a large superior portion of the abdominal cavity and a smaller inferior part called the pelvic cavity. The abdominal cavity extends from the diaphragm, here's your diaphragm, to the superior aspect of the bony pelvis, to the superior of the bony pelvis. So your bony pelvis is right in here. The top of the iliac wings will be right up in there. So it says the abdominal cavity contains the stomach, small intestines, large intestines, liver, gallbladder, spleen, kidneys, and pancreas. There's something unique about the kidneys, and we'll talk about that later on. The pelvic cavity lies within the margins of the bony pelvis, contains the rectum, the sigmoid of the large intestines, the urinary bladder, and the reproductive organs. The abdominal pelvic cavity, this is still on page 131, is a double-walled, let me get to your next slide, is a double-walled serral membranous called the peritoneum. So this entire encasement here, if you see right here, you got the parietal peritoneum, which is your outside covering, and you also have an inner lining called the visceral peritoneum. But all of your internal organs, this is obviously a side view, a coronal cut, but you can see where the pleural, or the peritoneum, I should say, peritoneum, is right here. It's that enclosure, that sac that encloses all your organs. So all of these organs here are enclosed in basically like in a plastic bag. And in a plastic bag actually has two layers. The parietal is your outside layer and your visceral is your inner layer. This is right above the liver. And there's also a space in the middle of these two. This is the same idea as with the thoracic cavity, guys. There's an interstitial layer in the middle of these two, the outer and inner layer of the peritoneum cavity itself. Okay? It says the outer portion of the sac is termed the parietal peritoneum. Here it is again, both areas right there. The outer portion of the sac, parietal, is close contact with the abdominal wall, the greater false pelvic wall, and most of the undersurface of the diaphragm. The inner portion of the sac, known as the visceral peritoneum, here it is again, it's that inside lining right there, that kind of brown with the blue highlight around it. And it says the inner portion of the sac is the visceral peritoneum. It is positioned over and around the contained organs. So it's all around the organs, and it's enclosed in a sac in itself. The peritoneum forms folds called mesentery and omentum, which serves to support the visceral portions of this and keep it in. I'll keep everything in line is what it's doing. And again, you can see here's where some omentums are. Mesentery, these are all ways of keeping all of these organs fastened down and basically kept in place. I'm still on page 131. I apologize for reading, but I just thought this would be a quicker way of doing it. The peritoneum folds, the space between the two layers of the peritoneum is called the peritoneal cavity and contains serous fluid. Because there are many mesenteric attachments of the intestines in the pelvic cavity, pelvic surgery can be performed without entry into the peritoneal cavity. The retroperitoneum is the cavity behind the peritoneum. Organs such as the kidney, the pancreas lie in the retroperitoneum. This is behind the entire enclosed sac with holding all of your organs. Your kidneys are located behind that. So that's why it's very, very important that we protect the kidneys. You know, we tell people never kick someone in the back. Well, guess what's right in the very back, posterior part of our abdomen are our kidneys. So when our kidneys are bothering us, we have lower back pain, and that's the reason for it. So I'm just going to kind of go over a little bit. I'm still on page 131. Here is our diaphragm, that dome shape. Right, remember that. We have the liver, we have the left lobe, we have the falciform ligament, we have the right lobe of the liver, we have the gallbladder, which is situated right there, that tiny little green dot, and that's where we're talking about when you have good scale of contrast, you're actually able to see the gallbladder, a small little ball, just a slight difference in gray values between the liver and the gallbladder. We have the ascending, the transverse, and the descending part of the colon. Here's your urinary bladder. You have the appendix. So anyway, you should be familiar with some of these some of this anatomy, and if not, here's time for you to review it. The majority and some of the more important ones that you're going to need to know when we're doing imaging of the abdomen, obviously it's going to be that the huge gland right here called the liver is located on the right side. So you'll be able to see that. Here is your stomach. This whole thing right here is the stomach. And right up in this top corner is where, remember I talked about a gastric bubble? Well, you can see why that gastric bubble is going to get there, because that's a very high upper portion of the stomach, so air will gravitate. All the others, all these, the bowel, the colon, the small intestines, we'll be dealing with that when we talk about fluoroscopy in the fall semester when you're doing all your barium studies. And here is your urinary bladder. Pay attention that it is very close to what? The pubic symphysis. So if you get just below the margin, the upper margin of the pubic symphysis on your abdomen / KUBs, then you've done well. So I really do. I like for students to palpate for the pubic symphysis. If you're uncomfortable doing that, I'm going to cross the line straight across. I'm going straight across. What am I hitting right here? What are these obvious, very prominent knots on each side of our femur? That greater trochanter. So you could actually palpate for the greater trochanter and put your crosshair, your horizontal line, going right across the greater trochanters, and you wouldn't have to necessarily medically palpate for the pubic symphysis. Okay, I'm turning over onto the next page. I'm talking about some of the exposures, breathing instructions, expiration, talking about what happens with the diaphragm, what respirations we need to be doing, whether we're doing it upright or if we're doing it supine. So there's proper breathing instructions that we will be talking about. Expiration, when we're doing expiration actually does what to the diaphragm? It pulls it up, so it allows all of your organs to have more room to spread out, so you're going to get a better picture of your internal organs of your abdomen if you take them on expiration. Remember, as you exhale, the diaphragm is moving up, so it's relieving that pressure when you would be otherwise taking a deep breath in. You're pushing all the organs down, squishing them in. Now, I can tell you that's a little trick for patients that won't fit on one plate. At times, we will get them to do the opposite and say, we'll get you to take in a deep breath, and it compresses all the internal organs so that they will all fit on one plate. But the best practice is for them to exhale all the air, and give them just a few seconds to relax, and all your organs will kind of spread out, and they'll kind of they won't be so superimposed over each other. It tells you here that the diaphragm moves about 1.5 inches between inspiration and expiration. So on expiration, you can actually get 1.5 inches more of the abdomen included on your image if you will just have the patient exhale all of their air. The diaphragm move positions from the upright to the supine. Obviously, when you're in the upright, everything falls lower. Everything falls down just because the natural pull of gravity. So the highest level is when you're supine. So when you're supine, the diaphragm and everything is the highest it can go. The lowest level is when you're upright. When you're upright, I'm sorry, we're saying this backwards. I apologize. Diaphragm moves position from upright to supine. The highest level is when you're supine. So when you're supine and you blow out all your air, the diaphragm's actually going up, which I did say that, and it helps to get everything to spread out. And then the lowest level is when it's upright, because everything is going to fall naturally with gravity. So even if you were to take in a deep breath and blow it out, all the organs are not going to pull up because you're going against the force of gravity. So let's see. These are just some of the positions that we'll be covering in our next video. This is obviously an upright abdomen. You can do an AP. You can do it AP projection, PA projection. You can do it, obviously, you can do it in a supine. You can do some of the cubes also. We'll be talking about that. But I just put this in here just so we could kind of get an idea of what we're going to be doing. And I do want to ask you a question about this one. This is the more one that you would do the most frequently would be this one. And the reason I would give you, obviously, this guy here is kind of toned and thin. But if you were to do this in a PA projection and a person happens to be obese in the abdominal area, what's that going to do as they try to get their upper portion of their abdomen into touching the plate? Well, you have the stomach there, so there's a problem with that. You don't want to lean them over like no bending, no flexing. You want them to stand straight up. Well, when you're doing them AP standing like this, they can get their entire back completely flush against the back of the IR. And also, when you're doing this AP abdomen / kidneys, if you're doing it AP and you're looking, or say if this was done for the KUB part of it, kidney, ureter, and bladder, where's the kidneys located at? The kidneys are posterior, so they're much closer to the IR when you're doing an AP projection. Okay, and here again, if it's a digestive issue, a GI tract, you're wanting to put the front part where all of your intestines are located, you would want to put that towards the IR. But this is a normal protocol here. Rarely will you see people doing the PA projection based off of what I just told you. Large percent of the population is morbid obese, so you have a stomach that you have to deal with, and you don't want to have the chest leaning in, trying to get it touching the board when you have a big stomach at the bottom that there's nothing you can do about. Okay. So here's some evaluation criteria. I'm going to just cover it just slightly, just showing you some of the obvious, and then I'm going to go back to your book. I think this is all I was supposed to cover on this little short video. But I wanted you to look at the differences of these two. Obviously, this is an abdomen. It's not got the bottom of the bladder. So this is what we call an abdomen. Here, this is a KUB. There's your kidneys. You got your ureters coming down, and there is your bladder right there. You can see at the very base of it, right above the pubic symphysis. They've got that upper margin of the pubic symphysis intact there. Again, you can cross it over. You're going to get your greater trochanter lined up with that. So this here is the difference between an abdomen. An abdomen, we're more interested in the GI tract, the intestinal tract, the small bowel, the colon, the liver. And over here, we're more interested in the urinary system, so we have to make sure that we have the bottom of the bladder. Well, at our sites, they want this for an abdomen. They want this for a KUB. So in other words, this is fine when you're doing this for an upright, and the reason I say it's upright abdomen, because I see there's a sign of the diaphragms. Everybody sees the bottom of the lungs here. So the diaphragm is right there. You're looking for free air. And notice that these arrows are pointing at something. They're pointing at how you can see these air levels. You see these straight horizontal lines. You see how that's leveling off. See how that one's leveling off. Well, if this patient was laying supine, you wouldn't have these distinct air fluid level lines. So that's an indicator that this was done erect, whereas this one here was done flat. There's no distinct levels in any of the intestinal tracts. They're all just bubbles, collected bubbles, trapped bubbles in the intestinal small bowel or the colon. But this is just something I wanted to show you, that we can have this discussion whether or not you're going to be doing an abdomen or are you going to do a KUB. I'll tell you, this is specific to the site that you'll be at, and I've learned over the years that here in our area, we are interested in this. The doctors want this for an abdomen. but they also want this upper portion right here called the diaphragm. We got to get a diaphragm shot. So they want the impossible. Rarely will an adult fit from the upper margin of the pubic symphysis all the way up to above the lungs, because as you can see, there would be no way that we could include all of that. So what we have to do, we have to actually go in there and have the patient do what we call a crosswise diaphragm shot. We're going to do an additional picture here. This would be your supine. You would do this one standing up. You would do this one lying down, and then they're still going to want you to come over here and get an upper a diaphragm shot or an upper abdomen. So what we do, we normally put it in and we do it crosswise, and we just capture the upper portion of this on an additional film. I know it's confusing. So I would want you to learn this is an abdomen. Okay, this is an abdomen for the urinary system, and it's called a KUB. The kidneys, they're outlined. These here are your psoas muscles, and obviously we have the bladder down here in the base of the pelvic. So it's going to, again, I apologize for it being confusing. It's just the way that our physicians here in our area, and I'm thinking Shreveport's the same, but you may want to ask when you're doing your comps, because this would count on, even on our comp form, it's got ABD/KUB. They're basically the same exam, other than the fact that it was for an abdomen. They want you to demonstrate the diaphragm looking for free air because there's some gastrointestinal issues and possibly what we call a perforation of the bowel, which means they've punctured somewhere in this bowel and they got free air, where that free air is going to gravitate up underneath the diaphragm. So that's the difference between the two. Now, if you happen to work at a urinary urology clinic, this is what they're after. They're after this right here because they're looking at the kidney size. They're looking at the bladder. They would probably be injecting some type of contrast. But again, at our sites, they want this here. They want the bottom of the pubic symphysis, and they also want the upper portion. So we have to include what we call a diaphragm shot. It is simply just right here. We put it another IR in. We center it up to the bottom of the IR to the level of the inferior angle of the ribs, and we shoot it. And that we just add that in, so that gives them pubic symphysis all the way up to the diaphragm. So in your book, it talks a lot about on page 134 and 135. Let me just see what our next slide is. This is just another criteria showing you some of the things that have to be that are very obvious on our images, and the indicators that we go after are called psoas muscles. These two strong bands of muscles right here, they're actually connected to the vertebral column, but they're showing up. If I back up and I show you, they're right there. There's this white line right there. It's a band. Those are your psoas muscles. Can't really see it because this patient has so much bowel area in the intestinal tract. They're hard to see, but you can see this gray area here. It's always going to be here on the right side. It's not completely black, so there's no air there. It's attenuated some, so it's a light gray. So that is the liver. So you'll always be able to kind of get your orientation if you look for this big spot here on the side. And of course, that's the liver always being on the right side. The other thing I will tell you that notice that the left kidney is a little bit higher, about an inch, inch and a half higher, because the right kidney is actually being pushed down by that big old organ. Right up here is your liver. So it's pushing down on the right. So your left kidney is always higher. So again, this is a MRI coronal view here showing you where the psoas muscles are and how thick they look. So they should be easy to identify. And you can see right there, here's one margin. There's the other margin of it right there. And this was a little harder to see, but it's right there. That's the band there and there. When you're able to see that's a kidney right here, by the way. So when you're able to actually see the psoas muscles, you're actually able to see them. You've got good overall contrast on your images. Here's some lower border of the liver. They're going to, here again, I showed you this big gray area right here. That's the liver. This is called the inferior angle. Okay, so we're always looking for that. That way we know that this is going to be the lowest part of the liver. So you know that your right kidney, and again, there's some bowel obstructing it, but it's right in there. And you can see right there, little metal artifacts. See how white they are? It's a metal. Those are clips because the patient has had their gallbladder removed. Because remember, the gallbladder would be right in there. This is your stomach. All of these patterns down here, all this down here, this black with some of gray, all of that is your intestinal tract. So that's all normal. Here again, they're showing you that with contrast, this patient's actually drank contrast, so now you can differentiate everything. And obviously, look right there. There's your gallbladder. There's your stomach. Here's your stomach over here. So you can see why lots of times things that have very low subject contrast, all of the abdominal organs, once we introduce oral contrast, you can see how much prettier we can see everything. Okay, here's again, there's your pubic symphysis. This is your pelvis, parts of your pelvis right there. Patient's got a gut on them. That's all gut right there. You have some, you have your flank muscles right there. You have them on each side. There they are again. See that little bit of dark gray right in there? Those are your flanks, the flank muscles. See them right there. This is just showing you your intestinal tract. This is another big thing that we do. We usually put a marker saying that they were done down, meaning supine, or we'll put a marker showing up and we put it up here saying that it was erect. Sometimes that's why you guys have the BB in your marker. So let's see what else we got. I'm not going to get into that quite yet, because that's going to be some of our positioning. So I'm going to stop sharing this, and I'm just going to come back and talk to you for just a few minutes. I'm not quite sure how long we've been talking, but I do want to so anyway, I'm hoping you're seeing me. So on page 134, it talks about the exposure technique. It said it is imperative to obtain maximum soft tissue differentiation throughout the different regions of the abdomen. Because of the wide range of thickness of the abdomen and the delicate differences in the physical density between the contained visceral, a proper balance of exposure factors is critical to show both solid organs as well as adjacent structures. So this is where we have to really stretch out that scale of contrast that we were talking about, that we have to be able to demonstrate all of the various types of tissues. And unfortunately, most of the tissues in the abdominal tract, the abdominal cavity, all have the same consistency, the same denseness to them. So they're really hard for us to see without introducing an oral contrast. But it says the best criteria on page 134 for assessing the quality of an abdominal radiograph is the ability to visualize each of the following. There's your psoas muscles. Remember, we showed that lower border of the liver, the kidneys, the ribs, and the transverse processes of the lumbar. And I guess I should have showed you that. I'll pull that back up real quick. Yeah, let me share that one more time with you. Let's see if I can pull that up. Sorry. All right. So right here, this is sharply defined outlines of the psoas muscles. If you just look up, there they are, big old bands right there. This is a little harder to see. Okay. And then it says the lower border, it says the kidneys. If you look for the kidneys are going to be right in there. And again, these are very hard to see. I can see the back of it over the, underneath this intestinal tract, the back of the kidney right in there. It says the ribs. Obviously, we can see the ribs. This is the 12th rib. It's free floating. It's not connected to the posterior part. And then it says the transverse process of the lumbar. You see these little legs coming off of each vertebra real faintly. Let's see if that back that we can see it any better on that one. Not really. This one you can see it real pretty. Right here you see these little side kicking out on each side of the vertebral body. That's what they're talking about. Those are the transverse processes. You should be able to see them. You should be able to see the ribs. You should be able to see the psoas muscles. And you should be able to faintly see the outline of the kidneys. So that is what they're talking about on page 134. Let's stop sharing that. Okay, so we talk about immobilization. It says the prime requisite in abdominal examination is to prevent voluntary, meaning what? We can control it, and involuntary movement. The following steps are observed. To prevent muscle contractions caused by tension, make sure your patient is comfortable and relaxed. It says adjust the patient in a comfortable position so that he or she can relax. Explain the breathing process to them early so they make sure they understand it, and give them time to do it and to relax. Even when it's blowing all the air out, hold it. Give them just a few seconds to relax their body. Explain the breathing procedure and ensure that the patient understands exactly what is being expected. Do not start the exposure for 1 to 2 seconds after suspension of respiration to allow the patient again to come to rest and to involuntarily movement of the viscerals to subside. Just give them time to relax on the table. Don't say, hold your breath, beat, blow out your air, beat. Give them time. Give them time to do it. Blow out all your air. Give them time to do that. Wait just a second or two. And you could even say, blow out all your air and relax. You could say that. That would be a good thing that you can add into your examination. Voluntary motion produces a blurred outline of the structures that do not have involuntary movement, such as liver, psoas, muscles, and spine. Patients breathing during exposure obviously it's going to result in blur. Involuntary motion caused by peristalsis, something we can't control. We can't control peristalsis. That's the active movement of the material through your digestive tract. So there's really not much we can do about that. It will cause a little haziness. So that was for your immobilization. Radiographic procedures, this is what I've kind of already talked about. I'm on page 135. It's going to explain the difference between the abdomen and the KUB. Radiographic examination of the abdomen may include one or more of these projections. The most commonly performed is the AP supine projection, often called the KUB, because it includes kidneys, ureters, and bladder. Projections used to complete the supine AP projection include, you could do an upright AP abdomen or an AP or PA projection in the lateral decubitus position, and it tells you there the left lateral decubitus is most often preferred, or both. The AP upright and AP-PA lateral decubitus are useful in assessing the abdomen in patients with free air. You need to know that word, pneumoperitoneum, and that is demonstrated on a lateral decube, assessing the abdomen of the patient for free air and in the determining and the presence and location of air fluid level lines. Other abdominal projections include a lateral projection or a lateral projection in the supine dorsal decubitus body position. Many institutions may also obtain a PA chest to include the upper abdomen and diaphragm. And remember I told you here we call it a diaphragm shot. We don't do a complete full chest. We just include the lower portion of the lung field. PA chest, this upright PA chest is indicated because any air escaping from the gastrointestinal tract into the peritoneal space rises to the highest level, usually right beneath the diaphragm. So that's why it's important that we get an upright abdominal film to include the diaphragm, or you can do it a KUB upright and do a diaphragm shot. Here in some facilities, we'll do a full chest x-ray. Okay, positioning protocols, not so much information there. The required projections obtained to evaluate the patient's abdomen vary considerably depending on both the institution and the physician. Some physicians consider the preliminary evaluation image, often termed a scout or a survey, to consist of only an AP supine position. It's just a general KUB, a general abdomen to include everything. Just one view. Again, you may have to do an additional of the diaphragm, but they just want to see overall what's going on, if there's excessive amount of air, if there's an obvious obstruction, things like that. That's what they're looking for. Others obtain two projections, a supine and an upright AP abdomen, often called a flat and upright. You'll hear that all the time, flat and upright. The flat and upright will both need to include the pubic symphysis and the diaphragm. That's here in our area, and I'm pretty sure it's, again, we can ask Dr. Curtis. I'm pretty sure they want the diaphragm, especially on the upright, because on the upright, what's going to gravitate underneath that diaphragm is going to be that free air. They have something called an acute abdominal series. May be requested to rule out air, bowel obstructions, or infections. The three projections usually include an AP supine, an AP upright, and an upright PHS. That's the normal routine for what we call an abdomen series. So that's another comp that you'll be doing. You'll do it a flat, an upright, and a diaphragm or a chest x-ray. Let's see, for the upright abdomen, if the patient cannot stand and you're still needing to get something demonstrating free air, if they can't stand for the air to gravitate underneath the diaphragm, that's when we do an AP projection and performing a left lateral decubed. In other words, we're going to turn them on their left side and give that air time to gravitate up under to the right lateral side, because it'd be the side up, air going up. Recommended sequence of abdominal radiography is not that important. I'm not going to read all that to you on page 135, but I do want to tell you this. It says to show small amounts of intraperitoneal gas in acute abdominal cases, recommendation that the patient be kept in the left lateral position on a stretcher for 10 to 15 minutes. You have to give that air time enough to move around all the intestinal loops to get to the top. So when you're doing it acute, and they're time consuming to begin with, but go ahead and roll your patient over into that left lateral position while you're setting everything else up, while they're on their stretcher or on the table, however you're going to do it. But go ahead and roll them up so that it gives it time. If there is going to be any air, it gives it time to gravitate up. I think you should read the rest of that column, and that's kind of important there. But I'm going to stop there. That was just a quick review on page 136 in your book. It shows in a large portion of the upright AP chest showing free air. And see, very little. You see how much, a little bit of free air under the diaphragm, but that could be an indicator of something more seriously. At the bottom on page 136, it's got AP abdomen upright position showing air fluid level lines. AP abdomen study supine showing intestinal obstruction. Look how much air is in that figure 4-8. Look, they're just all blowed up as tight as they can be. That's not normal to have that much air in the intestinal tract. So guys, I will pick up in just a little bit, and I will cover the next couple of pages talking about the actual positioning of it. This was your part one, just introducing you to the concept of the abdomen and the KUB. Please read your anatomy. Please understand the anatomy. Understand the difference between an abdomen and a KUB. And I will see you in part two. All right, take care, guys.